So many women get told like, well, everything's fine. Your ultrasound's fine. Your x-rays are fine. Your blood work is fine. Everything must be normal. But people are like, no, I'm really suffering. More and more, we're thinking of it like not just like a gyno thing. Number one, I would say the first problem is how normalized pain has become. That's just what periods are. People think that everyone has pain with sex. That's not true. That's a myth. Imagine this happened to men.
Hello, and welcome back to the show. I'm so glad that you guys are here with me. If you're tuning into this episode, you or someone that you love is probably struggling with a hormonal or a gynecological or a fertility issue like endometriosis and PCOS, which are the two main diagnoses that we're going to be talking about today. And I am really freaking sorry that you're dealing with that. I speak from firsthand experience when I say that it really sucks, and it can be really hard to get proper treatment and proper care and validation, but we are here to give that to you today. And the good thing is there's so much more research and awareness and experts who are sharing helpful info so that we don't need to just accept suffering and shitty symptoms as the status quo. In fact, just a week after I recorded this interview, PCOS was officially renamed to PMOS, Polyendocrine Metabolic Ovarian Syndrome, which is a way more accurate name since not everyone affected by this has cysts on their ovaries. And it also conveys that this isn't just an ovarian issue. This isn't just a reproductive issue. It's a full body multi-system metabolic issue. So we, throughout this episode, refer to it as PCOS since that change hadn't yet been announced when we recorded, but very pleased to hear it properly named and referred to. And it's about damn time that it's taken seriously as more than a fertility problem. And when it comes to endometriosis, even though it affects over 10% of women, it takes them on average 7 to 11 years to get an actual diagnosis after they first seek medical help for their symptoms, which often just get written off and normalized. But there are many amazing professionals bringing a lot of awareness to these issues, like today's guest, Dr. Karen Tang. Dr. Tang is a board-certified gynecologist and minimally invasive gynecological surgeon. She's an internationally recognized leader in reproductive health and has taught medical students and residents at Harvard, University of Miami, University of Pennsylvania, and more. She's the author of newly released book, It's Not Hysteria: Everything You Need to Know About Your Reproductive Health, But Were Never Told. And she reaches millions of viewers on her social media channels where she explains gynecological health, pelvic pain, and reproductive rights. This is such an informative conversation. I really hope it helps you. Teach us how to navigate women's health issues, Dr. Tang. Dr. Tang, thank you so much for being on the show today. I've been so looking forward to talking to you, and you do such important work in women's health. So thank you for being here.
Oh, thank you so much. I'm so excited to be here and join you. There's always something to talk about when it comes to women's health. So I think we're going to have a good time. So.
Oh, there sure is. That's true. I want to start. We're going to cover both endometriosis and PCOS today. And I want to start with endometriosis. A lot of people know endo as like a gynecological condition, but it's a lot more than that. Can you explain what endometriosis actually is?
Yeah, it is a very complex condition. So just like you said, more and more we're thinking of it like not just like a gyno thing. Like people think it's like a period thing, a pelvic thing. It's kind of a whole body thing. So like the official diagnosis is when tissue that looks very much like the tissue that normally grows in the cavity of your uterus, like the stuff that normally comes out like period blood, that's called endometrium, something that looks like that grows outside of the uterus. And that could be anywhere from, just outside the uterus, like right between the uterus and the rectum, or all the way to like your chest cavity. Most of the time it's in your pelvis. So most of the symptoms have to do with, like around the time of your periods. The classic symptoms are you have really, really painful periods, pain with sex, and also very common to have a lot of bowel problems because it oftentimes is right near your rectum. So a lot of people, like almost everyone with endo has like, really bad diarrhea, constipation, pain with bowel movements, bloating. There's something called endobelly where people almost look like they're pregnant. They get so bloated. And because it's stimulated by hormones with your cycle, people tend to have the most symptoms when they're either right before or during their period or around ovulation, but it can be any time. Like it starts to get worse and worse and people start to have symptoms like all the time. And it also is very inflammatory. So other things that even if it's not in an organ, it can make those things go awry. So people can get bladder problems. The muscles of your pelvis can seize up and not work well, or start to, hurt and cause problems with like the way that your muscles work when you're exercising or when you're trying to have a bowel movement. They all kind of start to not work so well. And it can also cause problems with fertility, where it can inflame your ovaries, your tubes, the eggs in your ovaries, your uterus, prevent implantation. So a lot of these things, like I said, are, we think of them as like the gyno stuff, but then there are people who are going to see their primary care or a GI doctor because they're like, why am I having all this diarrhea? Like, why does it hurt so much when I poop? And, like I said, it sometimes goes under the radar. Yeah.
Yeah. Oh, wow. Yeah. My mind was kind of blown when I learned that it can, like, those lesions can travel throughout the body, like it can really go into all different parts of you. So it's a lot more than I think what the average person realizes.
Yeah. Like, it's not uncommon to find it in the belly button, or like I said, it's not super common to have this, but you could get it in your chest cavity. People sometimes will bleed into their thorax, like when they have their periods, like they actually get blood in their chest. So it is a very weird condition. And it's very sad because we don't really know exactly where it comes from. Like, this is the sad truth about all of women's health. There's so many things. We just don't have the research. We don't know where it comes from. Like, does it travel through the bloodstream, the lymphatic system? Is it there when you are developing in utero? Like, we don't really know for sure. So it is.
So we don't know if it's genetic.
Condition. No, it probably is at least a little genetic because it tends to run in families. So people, it's often that we don't necessarily know if your mom or your grandmother had endo, but there will be sort of this family lore of, well, every woman in my family has had some sort of, problems with their periods, infertility, mystery hysterectomies. Hysterectomies don't treat endometriosis, but oftentimes, especially in the past, they were kind of done for anybody who was having everything was hurting and, they were bleeding a lot in a weird way. So they would take out their uterus. So they would have sort of this family history of everyone got a hysterectomy. Everybody had trouble getting pregnant. So it may not necessarily be that everyone knows that there was endometriosis, but when we take this family history, you very commonly hear this. And there's definitely times where people will be like, oh yeah, no, my sister had it. My mom had it.
Yeah, that makes sense. And is it classified as an inflammatory disease or an autoimmune disease, or how would you classify it?
Yes, it's very inflammatory. So basically, inflammation around where the lesions are can affect the other tissues that are around it. Autoimmune is a little bit of a different thing. It's where the immune system is actually attacking the tissue. There is a definite correlation, though. We don't exactly know what it is, but it is very common for people with endo to have autoimmune conditions as well. Sometimes a non-specific autoimmune where they have some positive antibody, but it's not officially lupus. But there's a lot of now talk about, there's definitely probably a connection with autoimmune disease. And then a few other things, including connective tissue disorders. So you may have heard of Ehlers-Danlos syndrome and something called POTS syndrome, where people's the dysautonomia, where they have trouble with the heart rate kind of being out of control. And then also immune system stuff. So I don't know, those of you who follow me on social media, I've recently made a couple of videos with my friend, Dr. Zachary Rubin, who's an allergist immunologist. We're talking about the connections between the immune system and reproductive health, and how the immune system is sort of affected by the hormones of the menstrual cycle. And so sometimes immune stuff tends to flare around the time that we have worse period problems like endometriosis. And so there is now some research that maybe the inflammatory system stuff can be part of the pain experience of endo, that the immune system is mediating some of the effects on the nerves, and that's why it hurts so much. So there's a lot to kind of learn about. We're just kind of starting to dig into the actual physiology of why this condition happens. Why does it cause these problems? So it is really sad because this affects millions and millions of women. It's at least 10% of girls and women, and people sign female at birth, because also trans men get this as well, that have all these horrible problems. And we're just well, we don't exactly know where it comes from. We're going to try and help you as best we can, but there's a lot of room for improvement for sure.
Yeah, there's so many interesting like correlations and links that I've read about. One of them was linking endometriosis to neurodivergence and like higher occurrence in those who have neurodivergence. Can you speak to that? Is that something that you've come across?
I actually don't know specifically about that. I wouldn't be surprised. I do feel like there are a lot of my patients who I feel like are neurodivergent, and that that's the whole range of everything: autism spectrum, ADHD, everything. So again, I do feel like we're going to eventually find that that's the case. Currently I don't have the specific kind of mechanism why that happens, but it does seem like that is probably going to show up as a pattern as well.
Yeah, interesting. What are the stages of endometriosis? What are the levels of severity that people should be aware of?
Yeah, so this is the interesting thing too. When people learn a little bit about endo and they learn about like the staging, so like stage 1, 2, 3, 4, I always tell people it almost doesn't matter. Unlike cancer, where the stage of the disease determines like what we do, how we treat it, what the prognosis is. There's not as much of that with endometriosis. In fact, it's almost what's called inversely proportional. So somebody with the least amount of disease can sometimes have the worst symptoms. So there's times that you go in and the person's like debilitated, like they can't go to work, they can't do anything, like they're just like almost paralyzed by pain. And you get into the surgery, and we'll talk about surgery in a moment, but and there's like a few little specks, like there's very little in terms of the actual amount of endometriosis. And then you have people who feel almost nothing, and they only are diagnosed when they are dealing with infertility. They're like, why is it so difficult to get pregnant? They find that their tubes are blocked. We do a laparoscopy, which is this minimally invasive surgery where we put a camera into the abdomen to see the endometriosis and actually remove it. And we're like, wow, it's everywhere. Like organs are stuck together. Everything is like, the anatomy is very distorted. And the person's like, I actually didn't feel that bad. Like I felt maybe like a little crampy, like a little bit bloated, but it wasn't so bad. So what's interesting, I always tell people, because sometimes we'll have a surgery and they'll almost be like disappointed that they didn't have more endo. And I'm like, no, we want it to be as little as possible. And we're just happy to have a diagnosis and remove it easily. That's great. That's what we want.
Yeah.
But sometimes people are like, oh my God, I felt horrible. Like, what do you mean there was just a few specks of it? I'm like, it has nothing to do with, like people think then that they're like overreacting, or that we're saying that they're overreacting. That's definitely not the case. It's basically just something about the disease. Like I said, in some people, the nerves get more affected, like they just have more of this inflammatory response, and they feel it much more, even if there's not that much. So that's like the first thing I know. And then the second is that there are times that it can get very severe. So like I tell people, like draw a little picture. I'll be like, it can be start like these little dots that are like little specks on the surfaces in your pelvis. And then it starts to, as it gets worse and worse over time, it can grow like into like little, we call them like nodules, where there's like a little clump of tissue that's inflamed, and like scar tissue kind of bunches around it. And then it can really be bad where it starts to invade into other organs. It's not a cancer. We kind of use the analogy of a cancer because people know that cancers start to grow into other things. It's not a cancer in that it's not going to, like hurt your like lifespan. It's not going to put your life at risk in most, I know I want to say it's like, people think like, well, I feel like it's going to kill me, but it's not going to literally like end your life, but it is going to start to kind of grow into other organs like your colon, your rectum, your bladder, and things like that. So it has that capability of actually starting to kind of invade into other things. And that's where it gets really bad, where it can affect like, your kidney function. If it blocks off the path of the urine to your bladder, it can cause like a bowel obstruction. Now, fortunately, that's very rare. It's not common that happens, but there's definitely people who have that degree of severe disease.
So what are some of the triggers of endometriosis flare-ups? I often hear people referring to flare-ups. So we know that, coming up, leading into and during the period, that's a common flare-up. Is there anything else?
Yeah, so a few things we know kind of flares endo. One is estrogen, so estrogen from your ovaries. So this is why people get kind of flares, like estrogen kind of peaks around your ovulation. So a lot of people will actually have little peaks of pain when they're right in the middle between their cycles. And then something about like the period itself, and like the uterus starts contracting and everything starts to kind of get inflamed and irritated. That's why people kind of get more pain like with their period itself. But the estrogen itself, and that's part of why a lot of the initial treatments for endo have to do with shutting down your ovaries production of estrogen. So one of the first line things that a lot of people get offered, especially when they're like teenagers and they're coming in with like really, really painful periods and like bleeding a lot and missing school, is just plain birth control. Birth control
Yeah.
actually suppresses the signal from your brain to your ovaries. That's why it keeps you from releasing eggs and getting pregnant, but it also will actually quiet your ovaries' production of estrogen. So people get confused because there's actually estrogen in birth control pills. They're like, well, wait, I thought this was bad for me. Overall, it's suppressing your ovaries' estrogen. So if you draw someone's blood and check something called estradiol, like it's going to be really, really low on birth control. So that's one of the ways that it works. And then the other thing that can kind of flare endo is foods. So there are certain, we call like inflammatory foods that tend to kind of trigger people's pain. It may or may not actually be stimulating the endo, but people can feel a lot worse when they have those foods. So, like red meat, sugar, dairy, gluten. And this is not for everybody. I always tell people, because they get kind of scared, they're like, I don't want to drop all those foods, but you don't have to quit every type of food immediately if you have endometriosis, but it's worth trying, like kind of keep track of what your symptoms are. What did you eat? What did you drink? What did you do that day? Like activity wise, like where are you on your cycle? Because it's very helpful to kind of see those patterns. People will be like, oh yeah, no, I can tell that it triggers my endo and causes a flare when I eat certain food triggers. And like I said, it's not all the case. And some people try all that and like none of it makes a difference, but some people do feel much better. Like they do feel like their pain, their bowel symptoms get much better when they avoid certain triggers.
That's interesting. Yeah, I've read a lot about anti-inflammatory diets and how they can help with endometriosis. Are there any other like natural lifestyle changes and supplement protocols or anything else that's not necessarily some of the more intense interventions or kind of artificial intentions?
Yeah, the most probably evidence-based thing is probably the physical therapy. So pelvic floor physical therapy, I send almost all my endo patients for. It may not necessarily, like I said, actually change the disease process, but it helps with everything else, meaning that like a lot of times endo has inflamed everything around it, like, the bladder, the bowel, the muscles, and a lot of the problems are downstream with the muscles kind of acting up. And then you have the pain with sex, you have like, your bladder, you have trouble controlling. It's hard to have bowel movements because the muscles are all seized up. So the physical therapy actually really, really helps with all those things. And it also downregulates the pain signaling. So this is where, you think about the disease itself, like the actual endo, you think about the inflammation, you think about the muscles, the other organs, and then you have to think about the nerves and how they're working and sending signals. So I use an analogy of like, old fashioned, like the telephone operators, like back in the day, when the call would come in, the operator would like kind of like respond and like, put the little signal through. I tell people, imagine somebody who's like, there's a million phone calls coming in and they're just like responding. And then somebody knocks on the door and they're going to kind of move as if they're going to respond with the phone because they're so used to the signals being calls that when they hear another sound, they're almost going to like reflexively be like, oh, it's another call. It's kind of similar to that where people with endo start to have everything turn into a pain signal, even if it's not a painful thing. So people start to get like their vulva hurts, like sometimes like, just touching the skin of their vulva is burning and painful. Obviously, there's nothing wrong with their vulva. It's perfectly normal. It's just that the nerves are so like inflamed and like they're just, functioning like haywire that we actually have to kind of roll back some of those, miswired kind of nerve signals. And the physical therapy actually helps with that. It was actually really amazing what they can do. So they do quite a lot of stuff. They can also like release like scar, like if things are a little bit stuck from scar tissue, they can help release that. Sometimes people with endo have scar from the endo or from the surgeries. So the physical therapy is really, really helpful. There's not like great evidence about other modalities. Like I do have patients who try like CBD products, medical marijuana. They do find it's helpful. There's not like amazing like studies showing that it's like incredibly helpful, but a lot of patients have told me that they've tried these things and they did help with their pain and inflammation symptoms. And then just in general, like anything that, helps with kind of just like down regulating your nervous system, therapy, meditation, exercise, all those things. I never tell people like, exercise is going to fix your endo, but it's obviously good for you. It does help with just like the overall kind of, like everything is overly stimulated. Just anything that kind of helps down regulate some of that stuff is helpful.
That makes a lot of sense. That's so interesting about the physical therapy. That's really helpful to know.
Oh, yeah. I had a great residency. Like, it was a Harvard residency, and I didn't learn about pelvic PT until I was in my specialty training for endometriosis care. I'm like, what's that? Like,
Wow.
and
Wow.
now luckily more people know about it. There's a lot of people who are pelvic PTs on social media, and they have huge presences and stuff. And now people at least have heard of it most of the time. When I first started practicing, people were like, what? Like, pelvic
Wow.
what? And it's great. It's very evidence-based. It's extremely effective. There's no risk to it. It's basically just the time to do it. Yeah, people love it. Like, they come back, they're like, oh my God, I wish I'd known about this years ago. So
This is when the power of social media is, and podcasts, to be honest, are amazing, because I've learned so much about hormone health, just so much about my own gynecological health through following experts on social media. That's how I found you, and you kind of get to access things that you might not come across normally. So
yeah, I learn things all the time. So another thing we kind of touched on was the immune system stuff. I honestly did not know that there was such a significant connection between the immune system and like the menstrual cycle. And now, again, we're not telling people to go out and use these things, but a lot of people on social media have started doing like the antihistamines, like the H1, H2 blockers, Pepcid, Allegra, Zyrtec. Combinations for things like premenstrual dysphoric disorder and endometriosis pain. Like I said, there's literally no studies on this. Like, we haven't actually studied those for use. So as a doctor, I can't be like, yes, go out and take these things. But a lot of people are reporting back saying that, they're like, oh my gosh, like my PMDD completely went away. And so I do believe that there's something to it. I do think that we need to study it. So I'm very interested. Like I said, that's why I made those videos with Dr. Rubin. I was like, there's something to this. Like, there's definitely, the future, we're going to learn that this is going to be, something can be used for actual treatment in this way. So I would never have heard of that if not for social media and people talking about it. I always caution, obviously there's crazy stuff on TikTok. Like, you don't want to listen to everything you hear on TikTok, but when like lots and lots of people are kind of coming forward and sharing the same experience, you're like, oh wow, that's a real pattern. So
yeah, that makes a lot of sense. And that's honestly one of the things I love about your approach, because we'll get more into this later in the episode, but I have like pursued, and asked medical professionals for like symptom management and asked about different things. And they're very quick to shut it down and be like, nope, we don't have evidence. So there's not, I find often a lot of curiosity about, we don't have the studies on that. But then again, we're lacking a lot of research and studies. So anecdotally, here are some things we're hearing, but I can't tell you that this is like a one-to-one, yes, this will work. But here's some of the things that we're starting to hear in the zeitgeist around this. So it's really helpful to have that curiosity as we look into what else could help with these very
this is how we advance the science. Is that, especially in women's health where there's so little research and we're so behind the eight ball, we have to balance, like I said before, like you have to balance like what can we actually say with evidence behind it, and what is that humility of saying like there's a lot that we don't know and that we have to know, and that we need that openness to listening to people's experiences so that it will help guide us. And that's the whole reason my book is called It's Not Hysteria. I'm holding up there because like so many women get told like, well, everything's fine. Your ultrasound's fine. Your x-rays are fine. Your blood work is fine. Everything must be normal. But people are like, no, I'm really suffering. Like, I'm having a lot of pain. I can't work, and this is not just for endometriosis, but like perimenopause, hormone experiences, all these things. And so much of women's health is not detectable on a test. So it's not like a heart attack. It's not, a diabetes diagnosis. It's so, like I said, we either don't have tests for it or it's all based on experience. So like pelvic floor stuff, there's no x-ray for that. It's just based on knowing what the symptoms are and being able to feel a certain muscles. If you don't do that, you'll never find it. And same thing with endometriosis. If you don't know about it, like it won't exist for you. So this is where having that like humility and like openness and we're always trying to improve our knowledge and keeping our eyes open for new avenues to be learning about things. So and I definitely, I feel for a lot of the doctors who just, they're so overwhelmed. Like I always tell people this when they're like, I had not the greatest experience at the gynecologist. They were really rushed. This is just, unfortunately, the healthcare system. I tell people like the poor OBGYNs get like 5-10 minutes with patients. It's not their fault. Like they would love to spend, I have my own practice. I can spend an hour with patients if I want to, but they're like, no, if they're making me see like 50 patients in a day, I can barely talk with them. And so, the doctors also would love to dig into it a little bit deeper, have the time to like look up things. And that would be the ideal world. Like, we should have a healthcare system like that. But unfortunately, just the logistics of, there's you could do a whole other episode on the healthcare system and why it's failing women.
Oh, we sure could. 100%.
Yeah.
And I do like that approach of assume positive intent that,
Mm-hmm.
that everyone is trying their best within a system that is not working optimally. So I do appreciate that. But I also, have seen online a lot of people talking about how their endo will take like 10 years to diagnose and just the stats on how long it takes to diagnose endo. I'm curious, like what's behind how long it takes? Is it that their symptoms aren't being believed or that the testing is so invasive? What's going on?
Yeah, several things. So it is a very long time to diagnosis for several reasons. One is, like we talked about, it's not like a simple test. So, somebody who, goes in for an x-ray and they're like, oh, you have like a broken bone. Like it's because for endometriosis to confirm the diagnosis, like you have to do the laparoscopy. Like you can have what's called a clinical diagnosis based on just like the description of the symptoms and like it sounds like endo. We can say, yeah, almost certainly of endometriosis, but to like 100% confirm that that's what's there, you do a surgery like a laparoscopy, put a camera in, get the specimens, like remove it, send it to the pathologist, and they say, yes, that's endometriosis. So, obviously not everybody with painful periods and bowel problems is getting surgery. So number one, I would say the first problem is how normalized pain has become, especially for girls and women. So there's sort of this myth that like, oh, everybody has horrible periods. That's just what periods are. So, you get like these teenagers who are throwing up and missing school and they can't function. They're like curled up in a ball. But people are like, oh, just like everybody has bad periods. So, several years pass. They're like, you're just a teenager with bad periods. Or maybe like they'll give them birth control because a lot of times birth control does make periods better. So, and it's true, like a lot of times it makes it better. That's all they need. They oftentimes need birth control if they're sexually active anyway. And then, the bowel stuff is also very normalized. Well, like, oh, there's almost like a joke on TikTok. It's like, I don't want to like be stupid, but just they're like, oh, the hotter you are, the more bowel problems you have.
Oh, yeah. Hot girls have stomach problems.
Like just a hot girl GI problems. Yeah, like everybody has diarrhea. It is just so normalized for people to have bowel problems or painful sex. Like people think that everyone has pain with sex. That's not true. That's a myth. It's not uncommon, like maybe the first time or like if after having a baby or things like that, but it should never be like super painful, especially not like on an ongoing basis. That's not right. And so all of these things being so normalized that people think that just, well, every woman has these problems. You're not going to get testing for it. So I always say, imagine this happened to men and you had a man who was like, I am in excruciating pain, like a quarter of my life or more, like a half of my life more. And I'm having diarrhea like constantly. I'm bloated all the time. It hurts me to have sex. Maybe I'm struggling to, get pregnant, to have a family with my partner. And, I'm like throwing up, like all these things. There is no way that we just be like, yeah, just everybody has that. Like, just deal with it.
Yeah.
But
it would not be
that's
dismissed.
the case for women.
Yeah.
They just tell women this. And so literally like time goes by. And then a lot of times people kind of get stuck in the like, let's just try every birth control that there is pattern where they're like, let's try this birth control. Let's try this other one. Try a NuvaRing, try an IUD. It's a great idea to try one. But if you're like, oh, multiple things aren't working here, let's think about what else could be going on. Like, let's do some more testing. Let's consider endometriosis. So after Roe v. Wade fell at the Dobbs decision, a lot of people came in for sterilizations. So tubal sterilizations, they were really scared. They're still really scared. And so a ton of people came in to get their tubes tied. So I was on a list of like a child-free Reddit group has like a list of doctors, gynecologists, and urologists who will do sterilizations if you're child-free. So I had a huge number of people coming in just from that list, from social media. And at one time, we must have gotten like literally 50 calls a day for sterilizations.
God, wow.
So I was doing a ton. And I probably found endometriosis in at least half of the people I operated on. I should have written it up. I just never had time. But I literally was like, this is literally like doing a study on how common endometriosis actually is because I'm doing the surgeries. And it was always the case that people were like, I had horrible periods when I was younger. They put me on birth control and it worked. and they needed it for preventing pregnancy, they wouldn't have thought otherwise, would never have had the surgery because they were feeling fine. But it was like almost like the epidemiology of how common this actually is.
That's
People,
so
a lot
interesting.
of times don't end up so bad that they need surgery. So they wouldn't have known. So I think it's the known percent is 10%, but I think it's way
Probably more.
higher based on that surgical experience. It's probably a huge percentage of the population that's assigned female at birth.
Oh, that's so interesting.
Yeah, isn't that crazy? I put it on my consent forms. I started saying laparoscopic bilateral salpingectomy for sterilization and possible excision of endometriosis. It was just so common. Yeah.
Oh my God, that's insane. What an interesting study.
I should have
You
written it
mentioned
up.
the laparoscopy surgery that's required to diagnose. Is it correct? I haven't fact checked this, but I recently saw that they've now removed the requirement to get the surgery in order to get a diagnosis for endometriosis. I think that just was maybe in the past few weeks that this has been updated. Is that true?
Yeah, so I made a video in response to this, and I love ACOG. It was just the ACOG annual conference just last week. That was always the case. It's a little funny that they're like, we've made this announcement and this policy statement. It was always the case. Like you could always have diagnosed it clinically.
This is just like a PR move.
It's the same thing. Like you wouldn't do anything differently, meaning that like if we suspect based on, you have X, Y, and Z symptoms, like we would start with like, maybe let's try some hormones to see if it helps. If that doesn't work, then we should consider the surgery. Like that's always been the case. We never kind of take someone right to surgery. Like, we unless they prefer to, like some people are like, look, I just really want no medications, no hormones. And that's obviously they're right. But we would otherwise treat people exactly the same. Like this has not changed anything about how experts manage endometriosis. So, it is a little funny. They didn't really actually consult endometriosis experts in the making of this policy statement because we were like, well, you guys should have been doing this anyway. But what it was helpful for was to help raise awareness about what the symptoms are and that this sort of cluster of different things could be very, very suggestive of endometriosis. You should really think about that and then manage them accordingly. And then, like, as a part of the bigger problem is, and part of the reason for the delay in diagnosis, didn't kind of finish that answer, was that, surgery is not like a straightforward thing. It's, people are nervous about taking people to surgery. They're like, well, but there's risk to surgeries, which is true. But I always tell people there's also risks of not doing the surgery. Like if you don't do the surgery, like it could start to grow into your colon, like it can cause infertility. It's not benign to ignore it. So but like there, general OBGYNs who have to handle a lot of different things, like they're managing life or death situations in, the labor and delivery unit. They are, like diagnosing cancers, like they're doing a lot of stuff. So, learning to do difficult endometriosis surgeries, which a lot of times they're very difficult because they're right next to other organs, they're involved with other organs. It's not something that a lot of them feel really comfortable with. So that sort of punts the decision about surgery later until it's more severe. So like these are part of the problems too. So like I said, the whole system kind of fails people at different points.
Yeah, this makes sense. This definitely makes sense. I want to talk more about that pain piece that we were just touching on as well, because I do think for anyone listening who has terrible periods, but just kind of has assumed everybody does, how do we gauge what normal or acceptable period pain is / is there any such thing as normal period pain versus like, this is a concern? Go you should talk to someone about this.
Yeah, that's a great question. And actually in the book, and It's Not Hysteria, I do have like several chapters on like preparing for a visit, like when is this a problem? Like, how do I talk to my doctor about what I'm experiencing? Because so much of this is just subjective and not like, here's like a blood pressure measurement. So the punchline is if it's affecting your quality of life or your ability to function and do the things you need to do in your daily life, that's not okay. So, normal cramps like period problems are just like kind of mild. Like you're like, meh, I feel a little crampy. I take an ibuprofen. It goes away. I live my life. If you are unable to go to work or go to school, you can't have sex, like you can't exercise, and it's really interfering with your ability to function in like day-to-day life, that is never normal. So we just tell people it doesn't necessarily mean that there's definitely endometriosis. It could be something else going on, but it's not normal. Like, like being debilitated by pain is not okay. And that's the case for anything, pain with sex, hormone symptoms, etc. Like if impeding your ability to live your life, then you should talk to your doctor about it. And like I said, just kind of keeping track of what exactly the symptoms are and, when they occur. It just is helpful to kind of jump in to the doctor's appointment and be like, look, every time I'm period, I have profuse diarrhea. I have extreme pain with my bowel movements. It hurts to have sex. And just kind of like literally like collecting it all. And then it just kind of makes the most of the time that you have, because a lot of times these appointments are fairly short. You have to kind of just jump in, hit the ground running. But that's the first step, is knowing what's abnormal, and then kind of coming to the appointment with that preparation about like, here are the things that are bothering me the most. Like, here's how I have tried to do something. I've tried ibuprofen, it doesn't work. Like, and kind of just like skipping past all the, well, have you tried ibuprofen? phase of things. You're like, yeah, I tried
full
that.
Picture. Yeah.
Yeah. And it's the same. So for bleeding, because people ask like, how much is too much bleeding? So we sort of say for that one, it's a little bit more quantifiable. So we say like, if you're soaking through like a pad or a tampon in like an hour, that's too much. Or if you feel like you're constantly like changing pads or tampons, menstrual cup, like one should last you through pretty much a whole like work day or school day. If you're emptying it multiple times a day, that's too much. And if like, significant bleeding is lasting more than say like 7-8 days, and like you're like heavy bleeding for like 10 days, that's too much. Or if it's bleeding so much that your doctor's like, hey, you're kind of anemic, like your blood count's a little low, your iron's low, you're feeling really tired. So those are all things to get checked out.
I'm checking a lot of these boxes right now.
Yeah.
This is really good to know.
And then bowel problem wise, it is very common to have just normal, mild bowel changes with your cycle. So people going into the period, like luteal phase, like right before your period, get a little constipated. With your periods, they get looser. It's called period poops. So just like a little constipation, a little bit of looseness during the period, that's completely normal. Like a lot of people have that. But if you're like, oh my God, it's so bad, I can't get the poop out, it's been like 4 days, like it hurts a lot, or I'm having like constant watery diarrhea, like that, those are abnormal.
Okay, good to know. And do you have any other tips other than, kind of showing your work, like bringing to the doctor, here's what's going on, tracking everything, really having like a good overview of your symptoms and what you've tried? Is there anything else for people who feel maybe a bit dismissed, or like the gravity of their situation isn't really being heard? How do we advocate for ourselves in a medical setting?
Yeah. And that's like the last couple of chapters of It's Not Hysteria are literally that. That's like, okay, so how can I make the most of these appointments? Like, what do I do if my doctor's not listening to me, et cetera? So, number one, like I said, is kind of like the preparation. Go in with literally like your summary of, these are the most important things to me. And I actually, when I start appointments, I tell patients like, tell me what the most important thing to you is today. Like, what's the most bothersome thing, the biggest priority for you to kind of get out of this appointment, or just your treatment in general. And then, like kind of like collecting all this stuff just so you can kind of, again, I always say hit the ground running. Like, you're not spending 15 minutes for them being like, tell me about how often you have your periods, like that obviously takes a lot of time. And then, the book too, like the way I kind of framed like each chapter was sort of to say like, okay, here's a typical experience of somebody with PCOS, with endometriosis. And so you can sort of say, wow, I have really bad pain with periods, pain with sex, I have diarrhea, it hurts to have a bowel movement, I think I have endometriosis. Like, that is very helpful to help the doctor kind of be like, oh yeah, those are endo symptoms, or PCOS. We'll talk about that later, but I'm skipping like 3 months of periods, like I'm getting more acne and facial hair, I'm gaining a lot of weight, I haven't done anything with my diet. Again, that just literally like kind of gets them that crucial information right up front and hits the ground running. The other thing too is like, have your list of questions, like think through, again, what are your goals? Like, people's goals are all different. So somebody with endo who's like, my main goal is having a baby this year, is very different from somebody who's like, my main goal is pain control, or, being able to like run a marathon again because like it's affecting my running. Like, think about what your goals are, your priorities. What do you think about different treatments? Because people have different preferences for medications, hormones, surgeries. You yourself, what do you think about those things? Because I always tell people, I never know before you walk in what you're going to want to choose for your treatment. Like, you had the same symptoms as like 5 other people. You could all choose different treatments at the end of the appointment.
Right.
think to yourself what your personal thoughts are on different types of treatments. So medications, hormones, birth control, surgeries, everyone has a different perspective on those. So someone is going to be like, oh, I only want surgery, or I really don't want to have surgery. I want to try medications I can control, myself in my house. So I always tell people, I never know before you come into the office what you're going to choose. Like someone can have the same exact symptoms and scenario and choose very different treatments for themselves. So think to yourself like what your preference would be. And then finally, it helps sometimes to like bring someone with you. Like I've had a lot of people bring a friend or a partner. Sometimes it's very overwhelming. That's a lot of information, and they might chime in. And this is great. I love when this happens. They're like, oh, don't forget, you wanted to ask about blah blah blah, or she was concerned about this and that. They can kind of back you up a little bit. And then finally, there are some times that, you kind of hit the wall. I say, they sort of say, well, there's nothing else we can try, or, you only have one choice. Like we can only do a hysterectomy for your fibroids. We can only give you birth control. There's never in anything in medicine that is like only one choice. Like even if it's, cancer, like there's several different choices. So if you get that answer, you always sort of say, well, what else could we consider? Like, is there other testing we can do? Are there other treatment options that maybe, like a gynecologist may not offer, but another specialist might have different input on? Kind of push them. I always say there should be a what's next. Like, there's never like there's nothing else we can do. There's always a what's next, like more testing, another, consultant, like maybe see if a different specialist has an opinion. So, like kind of like push them a little bit. And if they're truly like, we have nothing, there's nothing, that's when you sort of say, okay, I think I need a second opinion. And this is where, we said kind of in joking, but it's true, where at least some benefit of social media has made it easier for people to crowdsource finding a specialist in certain things. So this is the case for endometriosis, where sometimes it's hard. In your local area, there may not be an endometriosis specialist. A lot of people drive to come see me because they've heard good things through social media posts, like, Facebook groups for endometriosis, people with endometriosis. And so, it's helpful to kind of be like, oh, like this doctor here has really good feedback from patients, like they have really good experience. So, if you have the ability to travel a little bit farther to see a specialist, it may be helpful. Nowadays, for certain things, not so much endo because so much of it is in person, but for things like hormone management, for perimenopause, menopause, like there are a lot of people doing telemedicines for that sort of thing. So, for menopause, I tell people like Menopause Society has a directory of specialists. So sometimes you may need to actually see somebody who focuses in on these problems a little bit more as their specialty. It's not, that they do it all. So there are some general OBGYNs who are great at endo and a lot of them who don't because they're very OB focused. So like I said, it's sort of once you sort of get the sense that like this is not something that they like their main specialty is this, like then you go to see a specialist.
That makes sense. And then you can weigh out the options, which range from getting on birth control or kind of a hormonal intervention to surgery to hysterectomy.
Yeah. Yeah. And hysterectomy, like I said, is only for certain things. Like there's something called adenomyosis, which is like, it's like endometriosis, except it's in the muscle of the uterus, causes more like bleeding issues. So, it does treat adenomyosis, or if say endometriosis is like, fusing your uterus to your rectum, sometimes a hysterectomy is part of it. So it's sort of a myth that taking your uterus out makes the endo go away or that it prevents it from coming back. That's unfortunately not the case. And that myth sort of gets spread even by doctors sometimes. But there are certain areas where we are doing hysterectomies for endometriosis patients, but it's not for the purpose of like, oh, it's going to make it disappear or make it never come back again.
This was such a helpful overview of endometriosis. I want to switch over to PCOS and give that a bit of time and attention. Yeah, I was diagnosed with PCOS in my early 20s, and I was told by my doctor that unless I was planning on having kids soon, it just wasn't something I needed to worry about or seek any care for. And I think this is a really common experience where PCOS is labeled as a reproductive condition, but my very unsavory symptoms and I can definitely vouch for the fact that it impacts people way beyond fertility. I would love to hear how you classify PCOS in terms of whether it's a metabolic disorder or how are we viewing it now that we know it really extends beyond fertility?
We think now of PCOS as a metabolic condition. It is like with endometriosis, it's not just a gynecologic thing. It traditionally had been like, oh, this is about like periods and missing periods and infertility. But now that we know more about it, it's a hormone imbalance. And so much of it is tied to metabolic hormones like insulin and insulin resistance. So just to kind of take a step back, PCOS is an interesting condition. So polycystic ovarian syndrome, it's a terrible name. In the chapter on It's Not Hysteria, where I say, PCOS, it could not be a worse name because you can have PCOS and not have polycystic ovaries. It doesn't really capture
it's
what
basically
the condition is about.
Yeah.
So, and then people also think it means like giant cysts, like water balloons. It's actually very teeny tiny little like follicles that are in your ovaries. So again, the name does not convey anything about what the condition is about. So, hopefully people are pushing for it to be renamed something else. But in any case, it's not one condition. It's not like there's a gene or an enzyme, like in so many different things. We're like, okay, this is like the disease. It's a cluster of symptoms. So to be called PCOS or to have PCOS, you only have to have 2 out of 3 things. One is missing or infrequent periods, like you're not having a period on a regular basis. Like sometimes people with PCOS will skip many, many months between their periods. So number 1 is missing periods / ovulation. If you're not having a period, it usually means you're not ovulating that month. So that cluster of like, you're not having regular ovulation or periods. Number 2 is signs of excess testosterone, male hormone, except everyone has testosterone. It's not just in men. Women have it as well, just in different levels. But in PCOS, people have symptoms of it. Like they start to get like more acne, more facial hair, more body hair, and or they have high levels of testosterone on their blood work. You can actually have PCOS with perfectly normal blood work. Your labs could be normal, but you have the symptoms of like the acne, et cetera. And then the third is the polycystic ovaries on an ultrasound. And again, that is basically lots of little follicles that are kind of trying to be ovulated, except they're not quite making it. The hormone balance makes it so that your ovaries don't release eggs on a regular basis. So you have all these sort of like follicles that are not quite maturing, but they're big enough to see. So we call it a string of pearls. It almost looks like a little like kind of cluster of, a pearl necklace going around the border of your ovaries. And there's a specific number. You have to have a certain number. It's not just like you saw like a few of these cysts in your ovaries. So a lot of people get confused because they're like, oh, I had an ultrasound, I saw cysts, but cysts are a normal finding. Like everybody has cysts if you have functioning ovaries. It's a certain type and a certain number. So if you have 2 out of those 3 things and you don't have another condition that could explain them. So sometimes if somebody's missing their periods because they have like a thyroid condition or, they are an athlete and they, are exercising all the time and their periods have gone missing, that doesn't count. So you have to have ruled out other things that can cause some of these other symptoms. But if you have, then you're called PCOS or you have PCOS. The reason I mentioned that we think it's now like really a metabolic condition is something like 3/4, like 75% of people with PCOS will eventually have insulin resistance, which is prediabetes or diabetes. We think that the high blood sugars, high insulin are related to the problems with testosterone, with ovulation, et cetera. So it's something that we, like I said, it's not just about your period, it's about your whole body health. So people with PCOS have higher chances of not just diabetes, but also high blood pressure, high cholesterol. This is regardless of weight. There's sort of this idea that PCOS is only in people who are overweight or obese. That's definitely not true. And so people who are, completely normal body weight, very fit and healthy are, having insulin resistance, high cholesterol. They're like 25 and they're like, why do I have this horrible cholesterol? It's because of the condition. So it can cause fertility issues because obviously if you are not ovulating every month, you can have trouble getting pregnant, obviously, but it's not just a fertility problem. So again, it sort of has this myth that it's like people who are obese, who are infertile. It's a much more complex condition than that.
Yeah, 100%. And if you're an overachiever and hit all of the criteria, the diagnostic criteria, I see you because that is also me. I'm curious if you could outline the different types of PCOS, because my understanding is it can present more as insulin resistance. There can be more of a androgen related PCOS. How does that work?
Yeah, it's not necessarily that there are different types of PCOS. I actually think in the end, it's going to end up being different conditions. Like that
Mm,
sometimes like the presentation is so different from person to person that you're almost like, this is not the same disease. So right now, we don't know that there's actually different types of PCOS, but like for instance, some people can have the obesity and the missing periods. Other people can have regular periods, but more of the facial hair, acne, testosterone part. Some people have the metabolic stuff and some people don't. So, like I said, it's very different. It's actually interesting in like different like kind of parts of the world. People can have different presentations. So for instance, in Asia, they can have more of the not the obesity part, but the more the insulin resistance and things like that. So like I said, there's different kind of like clustering of symptoms in different populations. And this is part like why it may be kind of hard to diagnose. It's actually not hard to diagnose, I'll just say, if you have it on your radar, but why it oftentimes doesn't get diagnosed immediately is because say someone doesn't fit the typical, like the preconceived profile. They're slim, they have regular periods. A lot of people would be like, oh, they would never even think about PCOS, but will be like, oh, you are complaining about a lot of facial hair and acne, and you have the polycystic ovaries, and you do actually have a little bit of like the high testosterone. It's just that your periods are regular and you're slim. So, like I said, not fitting the kind of prejudiced idea of what PCOS is sometimes why people don't get diagnosed. And it's crazy because I hear all the time from people who have PCOS. They're like, I went to like 4 doctors. There's the actress Sasha Peterson, who I met through social media. She has actually been a very powerful PCOS advocate because I think she said she went to like 10 doctors. And when she listed her symptoms, they like classic PCOS symptoms. Like they couldn't be more classic. I'm like, how did this somehow miss like all of these doctors who know what PCOS is?
wow.
But, overall, she was like a relatively slim patient who, again, like the certain things didn't kind of fit what they thought PCOS was.
Yeah. Yeah. I know it's tricky. There's a lot of, I think, judgment surrounding PCOS patients being told like, oh, you just need to lose weight without kind of
Mhm.
factoring. And sometimes the way that PCOS works makes it harder to lose weight. So that's another factor that I
Yes.
think can be really frustrating for people.
Yeah, exactly. It's actually part of the condition that the insulin resistance makes it harder to lose weight. It makes you gain weight and put weight kind of like in the belly area, like it makes you retain fat. And then it makes it harder to lose the weight. So, again, back when I was training, so like I did my residency 2005 to 9, it was still very much framed as like if you lose 10% of your body weight, you can reverse the hormone imbalances. And now, again, it's framed more like if you get the insulin resistance under control, it's not just like go out and do a crash diet because like that's just not going to work. It's almost going to hold on to more fat if you try to like starve yourself. So the thought is that you need to get the insulin resistance under control. If you have insulin resistance, it's been known for a really long time that metformin, which is a diabetes medicine, was effective for treating PCOS. It would decrease the testosterone, it would regulate ovulation, it would help with infertility. There's a little bit more nuance now. There are other medications that are better than metformin, but just the idea that we knew for a long time there was this connection. But I think people didn't sort of piece it together like, oh, it's not just a weight thing. It's like it's the insulin, it's the blood sugar, it's knowing the metabolism and all this stuff. So, nowadays, a lot of things that we talk about are like we have people go see a registered dietitian and it's about the foods that you eat. Some of them like spike your blood sugar more. They're more likely to cause prolonged elevated blood sugars that keep your insulin high. And that's part of the problem. So it's not just like, eat less or exercise more. It's about being smarter about how things are affecting your blood sugar and, if you're trying all the right things and you do need a medication like a metformin or GLP-1 or something like that, that does help. So now, hopefully, a lot of people who manage PCOS are sending people to the registered dietitian to like be educated about like glycemic index, like how much are certain foods affecting things, not just being like, well, just good luck, like go lose some
Yeah.
weight.
Yeah.
Which
Yeah.
just like I said, the
Exactly.
poor people would be like, I'm trying, and like it's
Yeah.
not working. I'm exercising like crazy. I'm
Yeah.
running all the time. I'm still not losing weight. So
And weight loss isn't equivalent to healthy eating. Like you can be
exactly,
eating foods
yes,
that aren't good for you, but just at a real deficit. So that was such a missing link.
exactly.
There's a lot of
I'm
great
actually writing book number
naturopathy.
2. I'm writing book number 2 now. It's all about hormones, and I'm doing
Oh,
a chapter
amazing.
on weight and metabolism and how just like this fallacy of like, the calories in, calories out, you just eat less, you burn more. I'm like, no, the hormones are going to keep you from succeeding with that because your body's going to be like, well, we don't want you to be starving. So your metabolic rate will decrease if you eat too little. And, if you eat certain things that you think are healthy, but they're spiking your blood sugar, like a lot of like the health foods and like the bars and all that stuff like might, spike your blood sugar. So a lot of the things that, yeah, it's about like healthy, sustainable habits, making sure that you're getting strength training because muscle is so important and, fiber is so important. Again, cholesterol, people with PCOS have higher risk of cholesterol. We're like, make sure you get your fiber, that sort of thing. So it's about like kind of the whole body, well, like overall health and wellness, including like accurate nutritional information. It's never about nowadays, like most of us are not like go lose X pounds. We're like, okay, like let's look at your hemoglobin A1C, which is your blood sugar measure, and your cholesterol levels. And like let's make sure that we're, like helping with the things that you need help with and not just being like, like go good luck. just
Yeah.
just go on a diet.
Go hit the
Hopefully we were
treadmill
never
more.
like that flip about it, but
Yeah.
the message was definitely like, oh, I just got told to just
That
lose 10
rhetoric was out
pounds.
there.
Yeah.
Yeah, exactly. Yeah, historically, from what I've experienced and heard, was most people with PCOS were just kind of given the pill back in the day. But from what I understand, that's more just a Band-Aid. So you've touched on, nutrition and the importance of nutrition and managing blood sugar and glucose levels. What are overall the treatment options when you're meeting and working with someone with PCOS for not only managing symptoms, but also addressing the root cause?
Yeah. So we look at several different things. So like you said, the lifestyle modification part is a huge one because of the association with like insulin and cholesterol, et cetera. And then another part, and where the birth control comes in, and this is where I tell people, like, I can tell that a lot of doctors are trying to do it right. It's just they're not great at explaining it. So sometimes people will be like, they just threw this birth control at me and I have no idea why. The birth control part is for a few reasons. One is that if someone is going many, many months without a period, that actually is a risk for uterine cancer. So in these situations,
wow.
the tissue in the cavity of the uterus is building up over time and not getting flushed out. There's also a lack of progesterone hormone, which your body usually makes when you ovulate. And progesterone controls the growth of the tissue and keeps it from kind of, growing just completely out of control. So if you don't have progesterone, you're not having periods, you're getting all this tissue basically growing out of control for months and months. And over a long time, like over many years, that's a risk for uterine cancer. So the birth control protects the tissue. We call it uterine protection. It's basically, it gives you progesterone, it thins the lining and keeps it from, being out of control. And then also it, can give you more regular periods. It's actually not so much about bleeding. Like I tell people, the goal is not to make you bleed or to actually have like menses. It's basically to keep that tissue from building up. So some of the things that we give actually take the periods away. Like it's so thinned out that nothing comes out. This happens with like progesterone IUDs, with low dose birth control. It's so suppressed that there's no tissue to come out as a period. So some people are like, you were supposed to make me have periods and now I have no periods. Again, this is where the communication part is important. The goal isn't to make you bleed. It's actually to keep your uterus from developing abnormal cells. And then the
That's
other
so good to
reason we
know.
give birth control sometimes is actually decreases testosterone. So the estrogen in birth control, like birth control pills, actually increases a protein that binds onto testosterone and drops it. So a lot of times, for instance, like dermatologists will send patients to the gynecologist to get birth control for their acne and their facial hair. So even if they don't have PCOS. So the other reason the birth control is given is because of the testosterone symptoms. So again, like I think it's just, people are just not explaining at all the thought process. And they're like, here's some birth control. The people are like, I don't get it. But I think, hopefully once you explain it, it's a little bit more clear. Like there's a method to it. If someone doesn't want to be on birth control, but they're obviously they're making lifestyle modifications, but the periods are still missing, we would then offer something, we call it cyclic progesterone, which basically we give them every 1 to 2 months a course of progesterone to protect their uterus and to induce bleeding to flush things out. So there are ways around it. If you're like, I just really don't want to be on birth control or I don't need it, you don't have to be on it, but we do then at least give something to protect the uterus from the buildup of tissue. And then there's the fertility aspect. So obviously, again, if someone has tried everything and they're like still not having periods, but they're like, I want to get pregnant, then we would have people see a fertility doctor. It's actually among the things that make it hard to get pregnant, it's one of the easiest things to treat because you have so many eggs ready. There's nothing else wrong with the system. Like the tubes are fine, the uterus is fine. It's just the release of the eggs. And so it's actually relatively easy. It's almost too easy to get them to release eggs. So we have them see a fertility doctor called an REI, reproductive endocrinologist infertility. Those are the doctors that do things like IVF. And so they will help to monitor like the ovulation. They'll talk to people about whether they feel like medicines to make them ovulate are best, whether metformin would be helpful. Like I said, sometimes if people are insulin resistant, they would start with these medications for the diabetes. So like I said, it's not that they're necessarily going to be like, you need IVF, but they would talk through all the different fertility options that can help them get pregnant. So like I said, we think about the lifestyle, the metabolic health, the blood sugar stuff, the period and the uterus stuff, the skin treatments. Like I said, we partner with dermatologists a lot to manage the skin treatments. They can do things like, like laser hair removal, electrolysis, like the treatments for acne. There's something called spironolactone, which decreases testosterone. It's used for acne and facial hair. And
What's it
that's
called?
usually prescribed by dermatologists. Spironolactone. So
I haven't heard of
very,
that.
very common treatment for acne and facial hair, usually given by dermatologists. So it works. It's actually used for high blood pressure and heart failure. It's a diuretic,
Wow.
but it has this benefit of it has an anti-testosterone effect. So it seems to help with the skin stuff. So like I said, we partner with the dermatologist for that. So again, it's not like a one-man show. Like it's, very like kind of team-based kind of management for people with PCOS.
It takes a village, yeah. And then, so the endocrinologist can ultimately, in a lot of cases, if the natural lifestyle changes don't work, they're able to prescribe a hormonal treatment that would trigger ovulation. Is that usually the next step?
Yeah, there's different things. Like there's something called letrozole, which is sort of the gold standard for PCOS and getting people to ovulate for fertility. Like I said, if somebody has insulin resistance, then metformin could be used, and that actually can restore ovulation as well. We used to give it a lot when I was a resident to like everybody with PCOS, but because there's like some side effects with that, with like GI stuff, now and because other things are more effective, now we mostly use it for PCOS patients who have actual insulin resistance or diabetes. But like I said, that's one thing that actually can help them ovulate. And then, like I said, there's other like fertility treatments. There are times that with the fertility treatments that they actually are like, oh, if we just give you something to trigger ovulation, you're going to release too many eggs. Like this is with like the octomom kind of phenomenon where like a million eggs come out. And then they end up with like higher order multiple pregnancies. They may actually recommend IVF, not because there's something wrong with your tubes, which is, like the IVF is to take an egg out, fertilize it, put the embryo back in. Oftentimes it's done because like your tubes are blocked, or they need to like select, certain embryos, or there's a sperm issue. In this case, it's sometimes to control the number of embryos, because if they're just like, let's just stimulate ovulation, like 6 eggs come out. They want to be able to be like, okay, there's only one embryo. We're going to put it in and control it. So sometimes they'll be like, wow, you're actually really responding too well, and like let's actually consider doing IVF instead. So like I said, it's this is where the fertility doctor has to really look at your particular response, your numbers, how your eggs look and things like that. So whenever you see people, and I see this all the time on social media, where there's kind of like grifters who have obviously discovered that a lot of women are unsatisfied with how gynecologists handle PCOS, endometriosis, infertility. And they're like, I got the secret sauce. Like your doctor doesn't know, but this is the secret. And I'm a fertility coach, and it drives me nuts because I'm like, how can you possibly treat? They're basically doing medical treatment. Like it's not actual medical treatment, but they're pretending to. There's no way to do that without like literally being able to analyze someone's actual like blood sugars and their ovaries and their hormone levels and all this stuff. They just kind of pretend like they do. So if you ever see someone online being like, oh, I can make you have, I can fix your infertility from PCOS by being your hormone coach, like just run away. They're just going to steal your money. Yeah. It's totally garbage, etc.
There's a lot of snake oil out there. That makes sense.
It's so much snake oil. And they talk a good game. They use like the right words. They'll say insulin resistance and they'll say, metabolic syndrome, but obviously they have no medical background, or they're not, and they'll have a little caveat like, this is not intended as medical advice, but they're giving medical advice.
They're like, here's medical advice, but it's not intended. Don't sue me. Yeah. How about inositol and berberine? Are supplements like that, are they shown to benefit PCOS?
Inositol does have some data behind it. So inositol is a type of sugar. It's given in an over-the-counter supplement that actually helps with insulin regulation and blood sugar regulation. So even though it's a sugar, it can help with regulation of sugar. And there is some data that it may help. So there's actual data behind that, and then also behind like a keto diet. Now, I'm always a little careful about. I'm not saying like everybody go do the keto diet, but there are some studies on keto diet, which is like kind of a higher focus on fats, like some proteins, and then very low carb because of the association with insulin resistance. Now, the trouble with those kind of diets is very hard to sustain. So, and also people kind of go off the deep end with stuff that can increase your risk of heart disease because they are doing a lot of like saturated fats and like kind of red meat based fats and things like that. So I always tell people
Not
like
good for
there
the
are certain things
cholesterol
that have
counts.
yeah. There's like so I always tell people, you may have heard like, okay, like just go do this. Talk to your doctor. You always have to have a doctor kind of like managing this stuff. Inositol, it's a relatively low risk kind of option to try. And I do have a lot of patients who are like, I already picked it up and it did help. Like it helped regulate my periods a little bit. So it is something though, I would say that if you're trying it and you're like, well, nothing's really happening, or if you get any sort of side effect from it, obviously stop and then go talk to your doctor. But you also don't want to kind of just like self-medicate, because you could actually have like true insulin resistant type 2 diabetes, and that requires like a more effective treatment. So that's the other problem too, is it may not be effective enough if you have the real deal like problems with your blood sugar. So
That makes sense. Yeah.
we always put the caveat like,
really...
please consult your medical doctor.
Yeah.
This is not really intended as medical advice. Yeah.
It's for a reason, 100%.
Yeah.
And I mean,
course.
in terms of getting good dietitian and kind of naturopathic help, there's so many people that have helped me on that journey, and I've really been able to regulate and kind of correct my cycle by consuming stuff from like Glucose Goddess and just like really learning how to I tried keto, and it didn't work very well for me. It was really rough. I was really like fiber deprived. It wasn't great, but I was desperate. I was so desperate. And then just having such a moderate approach of like the order in which I eat food, trying not to have naked carbs so that there's less of a glucose spike, doing like the 10-minute walk after meals just to help keep those spikes down, and not operating out of, complete deprivation made a huge difference for me. The apple cider supplements, it's obviously different for everyone. Of course, not medical advice, but just I'm just so happy to report that years of really working on this naturally, I have seen real differences, and it's a huge relief.
It makes a big difference. Like, and this is where I'm really glad it's getting more kind of awareness, because I do think that just in general as a field, we have been a little bit behind the 8 ball. And now I'm really glad that we're focusing on like the metabolic health component of it, and like helping people actually get like real answers, because it has been very difficult for people. And a lot of people, like you said, like they almost feel like they're getting blamed. They're like, well, I tried the diet as hard as I could and it didn't do anything. That's because like there's, not everything is the same in terms of the approach. And like for PCOS especially, it's so like insulin kind of oriented and that sort of thing. So like you could do it, like I said, I'm sure you could do an entire other episode on like protein and strength training and building muscle and all of that stuff, and the keto diet and everything. Yeah. But it is helpful that we're starting to get more data.
Yeah.
Kind of back up these findings. Yeah.
My last question for you, we've talked about PCOS and endometriosis kind of in isolation. I'm curious if there's any links to, if you have one of them, you're more likely to have the other. Are they correlated in any way, or are they seen as just completely separate?
They do tend to run together. There's not like kind of an official connection. And the sad thing is, again, we just don't know the actual like kind of like, I hate saying the word root cause because it's sort of been co-opted to have a certain kind of meaning, but like we truly don't know the actual origin of these things. Like, is it a gene? Is it like a specific enzyme? So I do feel like I do have a lot of people who have both. Just like the endometriosis, I'm like, a lot of people have like ehlers-Danlos and POTS syndrome and like, mast cell activation, et cetera, that I do have a lot of people who have both PCOS and endometriosis. I have people, I call it the trifecta, which is like PCOS, endometriosis, and fibroids. A lot of people have that combination as well. Part of it too is just these are all very common things. So each of them individually is super common. So it's not uncommon that some would have multiple of those. So again, this is where people are like, say PCOS, endometriosis, fibroids, like, I have periods so irregularly, but when I do, it's like debilitating. I'm like hemorrhaging from the fibroids and I'm in excruciating pain from the endo. And, these poor people just like, are just really suffering. So again, to be determined. Anybody out there, I always put a little call out sometimes if you're a listener and you are in, basic science research or funding for medical research, please help us find the answers to these things because we need you.
100% we do. Yeah. And I
hope that one day a listener on one of the podcasts I do is like, I'm going to donate $50 million.
Please let it be one of you. We beg of you.
You never know.
I have a vested interest in this. It's so interesting because as I have kind of corrected a lot of my PCOS symptoms and gotten more regular, my periods have gotten excruciating. They've gotten my bleeding, my periods, all of it have gotten much worse. And then as of a few weeks ago, they're saying there's signs of adenomyosis.
Yeah. Mm-hmm. That's what I was saying. So, it's like, I call it a cousin of endometriosis. They're fairly similar, but they grow in different places. So it's in the muscle of the uterus as opposed to outside of the uterus. And so they can cause almost the exact same symptoms, except adeno is a little bit more likely to cause like super, super heavy bleeding and maybe a little bit more bladder symptoms because the uterus and the bladder are connected. Yeah. So if anybody out there that sounds familiar, it's in the endo-adeno chapters combined in the book.
Yes. So speaking of which, please tell everybody where they can get your book, where they can follow you online and get your incredible resources that are helping so many people.
Oh, thank you. Yay. So the book is called It's Not Hysteria, and it's basically everywhere you are able to get books. I do obviously put a big pitch to the independent bookstores. I'm a huge supporter of independent bookstores and booksellers. So if you have a favorite local bookstore, they can order it for you. And this is worldwide. So there's published for those of you who may be international. There are publishers for UK and Commonwealth and Spanish language, etc. So your local, favorite bookstore, libraries, a lot of libraries have them. Request at your local library. So it's a resource there. And then Karen Tang MD, KarenTangMD is the handle for all my social media. I'm most active on Instagram, also on YouTube, TikTok, and then KarenTangMD.com is the website. You'll have links for everything. I have a Substack too. It's barely active. It's called Gynomite.
I love it.
Gynomite.
Okay, you have a superpower for titles.
It's a
superpower.
I don't post very often, but I use it to like let people know about like book events or like, like I said, another book is coming out next year. So a year from now, to be determined the name of it, but it's all about hormones. So
amazing.
Stay tuned for an announcement about that book. So, but thank you so much for spending this time. I had such a good time. We could have talked for hours. Like you could
literally,
go on
we
could have.
There's so much more. So when your next book comes out, I hope you come back. That would be amazing. Thank you so much, Karen. This was such a great conversation.